welcome to this afternoon's COVID-19 seminar. I'd like to start by acknowledging the traditional owners of the land on which the campus is located, which is the Wurundjeri people of the Kulin Nation, and to pay my respects to elders past, present and emerging. So we've been having a few of these COVID-19 seminar series. I'm delighted that today I'm going to be co-hosting with Vicki Anderson, who I'll introduce in just a moment. It's been an interesting one. I co-hosted the first seminar series, which was on our getting kids back to school. And at that stage, we were still in a kind of form of lockdown. So I think it's an extraordinary testament to Victorians and particularly Melburnians that we find ourselves with the freedom that we have at the moment. And so congratulations to everybody, really. I hope you're all enjoying this afternoon. And we'll do this in an hour and then let you get back to some sunshine. So just a little bit about our COVID-19 program of research. This has been really a very rapid turnaround, as it has been for many organisations, but we've prioritised our research area around three major streams of work. One about prevention and treatment, the second around infection and transmission, and the third around mental health and well-being. And you can see the sorts of areas that we're focusing on, from COVID clinical right through to looking at the indirect effects. But from that, we've actually created three more, or a series, I should say, of strategic areas for direction. So you've already heard a number of these through the seminar series. The first is the back to school strategic area. Second is vaccine preparedness, which we had a seminar on last time. This time we're talking about the long-term actual mental health impacts on children and families. And the plan is for next year to have it on the physical impact. We'll be able to bring you some of the live updates on the BCG vaccine next year. We'll have a global health seminar and then talk a little bit more about infection and transmission in children. So the aim is to maintain this seminar series into the new year. A little bit about our COVID-19 steering committee. Apologies to those who have seen this before, but it really is an extraordinary achievement by the campus to bring together all areas of the Children's Hospital, the Murdoch and the University of Melbourne, and then across all of our areas from the laboratory through to clinical and then through to population health. And you can see everybody there, and you can see the number of papers and projects that have already been established. This next slide is not to sort of spend a lot of time on, but I do want to acknowledge, first of all, my co-chair of the actual steering committee, Professor Andrew Steer, or Steery as he's known to many of you, but also all of the other members of the steering committee who do an extraordinary job in helping us think through what are our strategic areas and how might we actually think through the sorts of questions we want to ask about children and adolescents over the next year or so. So today we're talking about the long-term impacts of the COVID-19 pandemic, and in particular, as I mentioned, the mental health impacts. We've got some extraordinary speakers. So what I'm going to do now is quickly introduce you to everybody who's speaking. What would be fantastic then is if you've got questions during any of the presentations or to any of the panelists, who I'll tell you about in a moment, if you could put them into the Q&A, that would be terrific. And then we'll be able to hopefully share those with the panelists. Vicki and I are going to work on that together. The other thing is I should just mention that this webinar will be recorded. So if you wouldn't mind acknowledging that when the button comes through, if it hasn't already. And also just finally, just want to thank the University of Melbourne's Department of Paediatrics, in particular Gus, who helps make this happen and provides all the technical support. So let me introduce our presenters today. So the first is Professor Vicki Anderson, who is Head of Psychology at the Royal Children's Hospital and Theme Director of Clinical Sciences Research at the Murdoch Children's Research Institute and a Professorial Fellow at the University of Melbourne. Our next speaker will be Meredith O'Connor, who's an Educational and Developmental Psychologist and currently the Program Manager of Life Course at MCRI, and she's going to tell you all about Life Course, which is a really exciting program for us. And finally, I'm really delighted to invite Dr. Neil Coventry to join us today. As you'll see from a number of seminars, one of the great and interesting things we've done is bring others to the table who are experiencing what's happening for COVID particularly through a government lens. Neil is a child and adolescent psychiatrist, but he's also currently the Chief Psychiatrist for Victoria. I'm going to share with you also the panelists, just so you have a sense of the exciting people also coming and start to think about what the questions might be. So our panelists are Professor Frank Oberklaid, who is the Foundation Director of the Centre for Community Child Health and who I've been very honoured to follow in his footsteps after 25 years. He's currently co-group leader of Policy, Equity and Translation at the Murdoch Children's Research Institute and co-chair of the Steering Committee and Expert Advisory Group tasked with developing a national children's mental health and wellbeing strategy on behalf of the federal government. Joining him will be Associate Professor Margie Danchin, who's a general and immunisation paediatrician in the Department of General Medicine at the Royal Children's Hospital and a group leader in vaccine uptake at the Murdoch Children's Research Institute. And she's a clinician scientist fellow at the Department of Paediatrics at the University of Melbourne. So I'm going to now stop sharing my screen. I'm going to hand over to Vicki, who's going to start our presentations, and then each of the presenters will just follow one after the other. Over to you, Vicki.
So thanks, Sharon, for that introduction. And just to begin with, what I wanted to talk about this afternoon very briefly is mental health issues in the context of lockdown, specifically for children. So my background is in psychology, and so I'm particularly interested in mental health issues. And before I go on, I just want to note that there's a large study team involved in this project across a number of different disciplines. And in fact, that's one of the really exciting things that the COVID pandemic has allowed us to do, collaborate widely across various different groups. So, minimize that. So I don't want you to focus too much on all the information on this slide, but what I really wanted to address is this issue of evidence around mental health issues in the context of COVID for children. And really, there's very little empirical evidence for us to go on. We all have our views and our intuitions, our professional opinions on how children will be managing the COVID pandemic, but we have very little information. So to date in the literature, in many of the highest quality journals, we have lots of people's opinions. So we have commentaries, we have letters, we have viewpoints, brief reports, and so on. Then we have a small number of studies in adults and an even smaller number of studies in adolescents. Nothing much coming out in terms of data on children or on children and parents. So there's a lot to learn, I think, and we really need to build evidence to be able to assist families to manage this pandemic and children's needs, but also future, heaven forbid, problems of similar type. Whoops. So just to really focus on the areas where kids have been impacted, as I'm sure you're all aware. So health has been a major issue, and I'll talk a little bit about that in a moment. Education has been a major issue. So online learning has been really problematic for many kids, and particularly the groups that I'm interested in who are already vulnerable. Home and family issues have changed, some for the good, some for the bad. Relationships with family, extended family and peers have changed, and leisure, play and sport are all restricted. So lots of changes for kids to deal with. And what we're interested in the research that my team's doing is firstly describing what the problems are that kids have in the context of lockdown, but more importantly, looking at what predicts the kids that'll struggle versus what predicts the kids that will be resilient to these really difficult times. And there's a lot of research out there in the literature that looks at traumas of various kinds. So quite a bit of research came out of Hurricane Katrina. There's some that's come out of the bushfires, as well as a variety of other traumatic events. And I think that we would all agree that COVID is a traumatic event. We may perceive it at different levels of trauma, but certainly has been a difficult time. So basically what the literature tells us is that there are various ways that people, including children, will respond to these kinds of traumas. So by and large, the majority of children and families will be quite resilient. So they might struggle for a while, and then they'll be resilient, or they'll be resistant, or in fact, some may even grow. So for these groups, as clinicians, we're just wanting to maximize the acceleration of getting back to this point. But again, as clinicians, we're particularly interested in these groups where there's delayed symptoms and chronic symptoms that we see. So the research that we're doing on campus is really looking to identify which kids fit into these categories. And we're particularly interested in kids who are vulnerable. So the groups that we're looking at are all Children's Hospital patients and their families. So kids with chronic and serious illnesses such as heart disease, or cystic fibrosis, or diabetes, kids with neurodevelopmental conditions, ADHD, autism spectrum disorder, cerebral palsy, kids with brain injuries due to stroke or accidents, and kids with mental health conditions, anxiety, depression, and so on. Secondarily, we'll look at those within each of these groups that are also socially disadvantaged. So we're imagining that these children and families will have more problems than community groups, which I think Meredith will talk to you about in a few minutes. So what we're interested in, as I said, is the level of trauma in these kids and families, what will predict their risk, but most importantly, what interventions and resources can we tailor for these families and for their particular level of need. So I'm just going to tell you a little bit about the study and give you a bit of a sneak preview of the data that we've got so far. So we've seen these kids at, well, we haven't seen them. We've surveyed these kids and their families at 4 weeks, and we're going to continue to follow them up to 6 months at least. And we're looking at a range of outcomes. So we're looking at mental health, both in kids and families, access to treatment and other supports. And we've looked in particular at screen time and the impact of education changes and online learning for families. So just as I said, a very brief snapshot of what we're finding in the first 50 kids that we've seen. So again, lots of details here, but the biggest message to get across is the increase in symptoms. So for anxiety, more kids, 8% more kids have got significant symptoms, and an additional 4% have moved into the severe and extreme range. Similarly for fatigue, that's grown quite a lot. Depressed and unhappy has increased, but not so much in the severe range, and so on. So if we look down this list, which I'm sure you can do, the main symptoms that we see, not surprisingly, are loneliness, kids not having face-to-face contact with their friends and their family, their extended family, irritability, and many of you will relate to that yourselves, not just with your kids. But I think it's also interesting that the majority of the symptoms are not extreme. So these kids haven't really tipped into the psychiatric level symptoms at this point, which hopefully is a positive for the future. What parents say is most stressful is pretty much in line with what kids are saying. So contact with other children is something that was identified by almost everyone. Reductions in informal supports, again, more than 3/4 of parents identify this. Access to leisure facilities, attending school physically, and for our group, most important were things like access to therapies, to carers and support workers, and respite care. So all of those things were seen as major stresses for these families within the lockdown period. And I thought you might be interested in this particular outcome, which was the time that kids spend on electronic devices prior and during the lockdown. So the blue line is pre-COVID and then during COVID. So you'll see here that there's a significant increase. So we've gone from the majority of kids spending less, up to 2 hours on screens. Now the majority are really 3 to 4 and even 6 hours on screens per day. And that we know that screens are not necessarily a positive, so there's a number of associated problems that come with that. So just to summarize that information, in these kids who are already vulnerable because of their medical illnesses and the needs associated, that what we see is an increase in all mental health symptoms, but not to an extreme amount, and not, as I said, not to the level of disorder. Social isolation and loneliness are key issues, which we would no doubt expect, with irritability also common, and screen use was significantly increased. For parents, the pattern was really interesting for these families, and just anecdotally, many families really felt that their mental health and stress levels were unchanged during COVID, with the comment that they were already very high prior to COVID, so it was a bit difficult to make them worse than that. What they did describe, which I think is concerning, is this issue of poorer partner relationships. So that means less support for the parent within the family environment. But there are some positive aspects of lockdown. So many families noted that the benefits of increased quality time with families, less running around, and people within the family looking out for each other. As clinicians, we've really got on the bandwagon with regard to telehealth. But when we surveyed these particular families who are frequent flyers in terms of their health service utilisation, 90% of parents rated telehealth as of lower quality than face-to-face contact. So I think that's a really important message that we need to think about as clinicians. And really, following on from that, kids' healthcare needs were felt not to be met, lack of access to therapies, and carers were major areas of stress. So just to finish off, I think we've got a lot of information on what the problems are, and now what we need to do is think about intervening. And I've just put up this model because I want to really emphasize that while we've identified all these problems, not all of these families need face-to-face psychiatric intervention. There's a range of levels that we can intervene on, from the prevention side of things, where we can provide good evidence-based resources, right through to short-term and longer-term treatment. And that's what we're going to be working on into the future. So that's it from me. Thank you. And I'm going to hand over now to Meredith.
Thanks so much, Vicki. As Sharon mentioned earlier, my name's Meredith O'Connor and I'm the Program Manager of the Life Course platform, which is the platform that brings together all of our fabulous longitudinal cohort studies at Melbourne Children's Campus. So as Vicki has already described, COVID has represented just such a significant disruption in the lives of children and young people, from school closures to reduced social contact, to rising levels of adversities like family violence, for example. So mental health is of really high concern at the moment. And part of understanding those impacts on mental health and well-being for kids requires us actually to look backwards and understand those long-term pathways leading into the pandemic. And that's because those experiences and skills that kids are developing and the services they interact with, and all of those exposures in the years and years prior to COVID are likely to have a really profound influence on shaping their risk and resilience in the here and now of the crisis. And as well as that long-term perspective backwards, we also need a long-term perspective into the future. And to understand those pathways out of COVID. And that's because we expect that the aftermath of COVID is here with us for some time to come. And that's where our longitudinal cohort studies provide a real wealth of data and a real resource to draw on. We've got over 40 cohort studies at the Melbourne, and together they've been tracking the health and development of over 70,000 children for years, sometimes even decades prior to COVID. And they'll continue to follow these kids up into the future. So a number of our cohorts have really rapidly pivoted to collecting data specifically on the impacts of COVID for mental health and well-being and other psychosocial outcomes for children and families. And as these cohorts come together, we're starting to get really rich coverage across that continuum of care that Vicki talked about. So we've got, for example, these population representative cohorts that can inform our thinking about prevention. What might we do out in the community to prevent these problems from arising in the context of COVID? Right through to the other end of the spectrum, where we have cohorts that have specifically been tracking children with particular health concerns. And that can inform our thinking about how we integrate mental health supports into the ongoing care for these children. I want to provide you with a few examples of what this looks like. The Australian Temperament Project Generation 3 study has been out in the field and collecting data on the COVID impacts for families over a web survey. They're now able to link this to that historical data from over 3 decades of following these families, and even with the capacity to look across generations, how that influences that COVID experience. That's one of our longest running cohorts, but we also have some new cohorts that have been established to ensure that we're capturing all of those groups across the continuum of care. And one of these is being led by Margie, actually, one of our panelists today, and is following up children who are, and their families who are presenting to that Royal Children's Hospital for COVID testing. And you can imagine that particularly in the early phase of the pandemic, this would have been a really significant stressor for a lot of these families. And finally, just as one additional example, Vic Child is a cohort that's specifically following those kids and young people with permanent hearing loss. So we'll be able to understand how COVID experience looks for that population and, for example, impacts on issues like health service access. So as we move from gathering these data to starting to get our hands into the data and analyse what's there, the picture that's emerging is really consistent with that notion of fault lines and of COVID as highlighting and potentially even further exaggerating what are existing vulnerabilities in our communities and our social structures. So, for example, I've been leading some work looking at the financial impacts of COVID for families with young children. And what we're finding is that those financial adversities like losing a job in the lockdown, they do happen at every socioeconomic strata, but the burden is disproportionately being borne by those families who had a long-term history of disadvantage before COVID hit. So these types of insights can be really helpful in informing our thinking about particularly the targeting of services and supports and where we might need to direct additional, more intensive resources and supports. So thank you very much. And I'll now hand over to Neil.
Thanks very much, Meredith, and good afternoon, everybody. It's a nice segue for me talking about mental health now after hearing about from Meredith and Vicki. I just want to really thank very much Sharon, Vicki and Frank and all my colleagues at Murdoch for the invitation to talk a little bit about mental health. It's a great honour. And before I start, I'd also just like to pay my respects to all the traditional owners of the lands, wherever we might be, and pay my respects to their elders past, present and emerging. I'd also like to acknowledge the importance of people with lived experience, both children and adolescents and their families and carers as well in sort of guiding this. So what I want to do is just take you very briefly into a little bit of the data around mental health consequences or impacts for COVID. And this is really important, I think, because often we're working within an adult paradigm, and as Sharon was saying, my background is child and adolescent psychiatry. I'm a child and adolescent psychiatrist by training, so very concerned that we don't forget about the impact for infants, children and teenagers. And one of the, I guess, areas we need to focus on is what have been the indirect or unintended consequences. So while we know that fortunately very few children have actually been impacted directly, as in being infected by COVID and suffering illness, we've had hospital admissions, but they've been pretty rare. And I think I'm right, Sharon, that to date we haven't had any deaths. But we do know the indirect effects in terms of mental health and well-being, and I use that very broadly, have been significant. And we've got some worrying statistics. So I was hearing about this from some of the literature overseas, but also from my colleagues in other states and jurisdictions, and thought we should actually drill down a bit. I'm sorry I can't present any fancy overheads because my department, being a public servant, I have to get approval to share my data, and we're a bit averse to sharing our data with people. I don't quite know why. It's a little bit of a paranoid view. So I'm not the data custodian, but I'm going to tell you about the data anyway, even though I can't officially present it on slides. So really what we tried to do is to after consultation with a number of my colleagues in emergency medicine and paediatrics and associated fields, thinking about how we drill down on the data that we've got. So we focused first of all at thinking about the data from emergency departments. And I need to stress, this is a bit like the iceberg effect. You're looking at the bit of the iceberg you can see, the really sort of top part, but most of it is underground and it's happening underwater, happening in the community. And we don't have a lot of data about that. But the data that we've got in emergency departments is actually quite worrying. So we did a different cut of the data to look at what it was telling us about young people. And there's been a huge increase in young people under the age of 17 attending emergency departments. Now this, I need to stress, is in the context of people during COVID lockdown not actually going to hospital emergency departments because we're all too frightened about catching COVID, so people keeping away. But for young people, that was actually the opposite. And they're presenting with intentional self-harm and suicidal ideation. The increase was very striking, almost 33% increase, which is very worrying compared to the previous time, the year before. And when you track this over months, the blips we used to see were relating to things like school holidays. The blips now are when we go from stage 2, stage 3, stage 4 lockdown. Now, if we look down a bit more about that and we look at the sort of triage categories, so the categories could be 1 or 2 is sort of the most severe categorisation when you go to emergency department needing resuscitation or emergency care. It's even more extraordinary with this under 18 group, a 72% increase in the medical severity. So not only are we getting more people presenting, the severity of their presentations is extraordinary. When we then look at what's happening in my field in terms of child and adolescent inpatient wards and admissions, we're getting something like a 47% increase in admissions compared to the same period in 2019. We now have pretty good relationships in my office with the coroner's department, so we get real-time data. And although there's been a lot of concern about suicidality, fortunately at the moment we're not seeing that translating to an increased incidence in completed suicides. That doesn't mean later on we might be seeing this, but at the moment it's suicide attempts, not actually completed suicide. So the number is roughly approximately the same as it's been in other years. But I do want to stress one sort of cohort that I'm particularly concerned and interested in. We're hearing anecdotally from overseas that there's been a bit of a tsunami effect of increased incidence in eating disorders such as anorexia nervosa in young people. When we drilled down in Victoria, we were getting the same sort of data. There's been almost a 30% increase in the number of children and young people, registered mental health clients, with the diagnosis of eating disorders. The anecdotal evidence I'm getting when I talk to my leaders in child and adolescent mental health, there's an unprecedented demand across the age range, including adults, but primarily with young people. We're also seeing this in some of the online support eating disorder tools. The Victorian Centre for Excellence in Eating Disorders was certainly saying in terms of their online usage, it had increased dramatically. Figures are a little bit rubbery, but an extraordinary increase. We also wanted to look at perinatal mental health, and I really pay my respects to my colleagues in CHOPM, the Consultative Council of Obstetric and Paediatric Mortality and Morbidity, where in terms of their perinatal emotional health program, almost a 40% increase in the number of registered clients, a 12% increase in the number of service hours compared to the same period. So this is what the sort of bit of the iceberg above the water is telling us. Really, really very worrying. I'll just say a little bit about eating disorders, because that's a particular special interest of mine, and thanks to my paediatric colleagues who were telling me that in fact, many of the young people presenting with eating disorders, we believe, have not, coming to emergency department, have not actually been in contact with any support services whatsoever. So their first contact is really at this pointy end. And even more worrying, many of them go to have medical admissions. They present so medically unwell so that they end up in paediatric wards or even paediatric intensive care, having medical resuscitation. So quite extraordinary, really. There's a whole lot of ideas about this. We don't really know the full story, but probably it is a bit that COVID and the impact of lockdown for some young people has been a perfect storm of the combination of factors that may contribute to an eating disorder. We don't really know what causes eating disorders truly, but it seems like this is the perfect environment for that to be happening. So this has been really, really concerning data. I just want to finish by talking about what we thought might be a good way forward with this. And this is clearly going to need something that's what we call a whole of government linked up response, but particularly linkage with health services, community and education. And I guess I'm very fortunate that my Minister for Mental Health also just happens to be the Minister for Education, James Merlino. So there's some great opportunities to get some linkages in a way we haven't been able to do before. So we're hoping that we can establish, or we will be establishing, a task force that will be giving, we hope, very evidence-based guidelines and recommendations to the government about a whole of government response, focusing on children, infants, children and teenagers and their impacts of COVID, so they don't get forgotten about when we talk about the roadmap to recovery from COVID. So really significant impact. We will get more and more data, I think, and get clever at how we analyse the data. But at the moment, the data we're getting is really incredibly worrying, and we know that we've got to intervene assertively and early for children and young people, just like Vicki and Meredith were telling us, in terms of these long-term impacts of this generation who have lived through the experience that we've had this year. And we hope we're on the way to recovery, but we need to be making sure that we're thinking about children and young people in a very robust, vigorous way, and we're also using the data to help guide us. So thank you very much for the opportunity. I'm happy on the panel we might get a chance to prosecute some of this further, but really just wanted to make you aware of what our data is showing us and what we might need to think about in terms of how we help people to recover. Thank you.
Thanks very much, Neil and Meredith. I think you've provided a great picture of where things are at and what we need to be thinking about. I'm going to take the co-chair's benefits and ask a question to Neil to start with. Just following up on what you've been talking about, Neil, we hear a lot regarding the mental health support from government.
Mm-hmm.
Does the Victorian government and your group, sorry, I've got a little helper here that's annoying. Hopefully he'll behave himself. Let me start that again. So can you tell us a little bit about the plans that the government might have, or ways that they might be thinking of utilising some of those resources? And I suppose I'm commenting on that in the context that there might be more money, but there's not really enough professionals in the field to go around.
Oh yeah, look, that's a that's a great Dorothy Dix. Thanks, thanks Vicki for that. Yes, look, and it is really a complex area because there's Commonwealth money and state money as well. I think at our state level, they will and truly are acknowledging the impact. And as everyone knows, in Victoria, we're going through a Royal Commission into mental health. So we're hoping. We thought our first crisis that the Royal Commission would need to deal with was the bushfire and bushfire recovery at the start of this year. No one anticipating about the pandemic, but I'm sure there will be some opportunities there. For me, it's important that we make sure children and young people get their slice of the pie, really, and it's a more complex sort of investment, I think, Vicki. It has to be whole of government, and, you know, as you were pointing out, and Meredith, I think we've got to be looking at colleagues that we need to be thinking about mental health in its broad sense, in terms of mental health and well-being, and, you know, pay my respects to my paediatric colleagues thinking about physical and mental health and eating disorders being the prime example of, you know, body mind, and how we need to think about that in a much more comprehensive way. I might just say one of the perhaps less counterintuitive things we're finding out is that young people haven't embraced what we call telepsychiatry or telemedicine, you know, using their computers and their iPhones in a way we might have thought, given how savvy they are with this. But the group, as you're pointing out, Vicki, in your presentation, the group of very vulnerable young people actually want face-to-face connection. And I say that in a concrete way. They want face-to-face connection without masks that disguise our faces, which we have to wear. So they haven't embraced telepsychiatry in the way we thought. So they've actually fallen off the pillars, really, I think, particularly as a lot of the community support services like Headspace, etc., had to stop providing face-to-face work. So these people missed out, particularly the vulnerable young people who are already somewhat disengaged from school, so they weren't being monitored there. So I'm really hopeful and positive that we've got the right perspective, Vicki, to think about a sort of joined up response rather than a very narrow mental health response. And I'm hoping that it won't be a narrow adult mental health response. It'll be much more a systems response for young people. And although I represent the specialist mental health services, all the work actually needs to happen at tier 1, tier 2 level. So our partners in primary health, etc., schools, paediatrics, that's where the work needs to happen, not at the specialist tertiary group.
Yes. Yeah, thanks, Neil. And just taking up your point about adolescents, we actually canvassed them in our study, and a number of them raised concerns around privacy during lockdown.
Yes.
So I think that is a real issue for them, and may well be indeed why they haven't taken it.
That's the thing. We were getting the same response in mental health too, Vicki, and sometimes it was just disadvantaged families not having the IT capacity, but a lot of it was actually people in families, young people growing up in families where they don't feel safe in the family that they're getting. And there are big issues about confidentiality and not wanting their family to overhear. In fact, for some young people, the isolation and the lack of opportunities to actually go out of your house was enormously challenging for people whose resilience actually depended on getting away from their families in some cases and being associated with their peers. It was actually really traumatic and challenging, I think, for them.
So a question for Frank now. Neil mentioned the close links between mental health and education. And Frank, I know that you and your group are doing a lot of work in that space. Do you want to maybe tell us, so my specific question is around what's happening in schools and how are teachers managing kids' mental health problems, but I'm happy for you to talk more broadly about your experience over the past months.
Thanks very much, Vicki. If I could just comment on what Neil just said, he's right. There's such an opportunity in Victoria because it's unusual to have the Minister for Education also be the Minister for Mental Health. And so we've got a wonderful opportunity, but Neil also said, and I just want to emphasize this, the complexity of this field, the fragmentation between state and federal, and the fragmentation between all the different professionals and settings. So there's no silver bullets here. Nevertheless, I think because of the Royal Commission, because of the Productivity Commission, because of the minister having those two portfolios. And the third piece of that is the National Child Mental Health and Wellbeing Strategy, which I've co-chaired, and the report is with the minister. And I believe the draft is going to be out for consultation next week. And we're very keen for that to be disseminated as widely as possible and for comments to come back. So there really is an opportunity, and we landed on schools as being a very, very important platform for a number of reasons. Primary schools, that is. All children go to school, almost all children. The often transient behaviour problems of 3-year-olds and 4-year-olds have either become entrenched or disappeared, and there are new problems emerging as the child have to negotiate social relationships and start to struggle academically. Teachers spend a lot of time with these children, so that it's a great opportunity to both prevent mental health, to promote resilience, but also to detect problems early on. So we've got a very strong partnership with the Melbourne Graduate School of Education. So that's bridging two of the areas that Neil commented on, health and education. And we created and co-designed a new role in schools called the Mental Health and Wellbeing Coordinator, and designed with Melbourne University a training program for those coordinators. So this year we've done a feasibility in 10 schools, looking at the feasibility of that role, looking at the training program. It's been extremely well received. Next year we're going to 26 schools, and that'll be the definitive evaluation. But the role of that coordinator, he or she will have 3 tasks or 3 goals. One is to support the classroom teacher about identifying children who are starting to struggle with their mental health problems, but also dealing with fairly straightforward social and emotional issues in the classroom. Second, he or she will be a resource for the school. He or she will coordinate all the mental health issues through the school. And then thirdly, and importantly, the idea is that that person will be a bridge between the school and the community. So part of the work is a generic mapping template that each school will populate. So he or she will know where the referral networks are, and hopefully we'll be able to facilitate those referrals. So that's a very exciting project. It's been well received, and it goes some of the way to trying to bridge those different professional groups, and particularly education and health.
Thanks, Frank. There's a question that is here for Margie. Margie, you've already talked about all your many hats in the COVID pandemic. And maybe you could talk to us a little bit in this context about the work that you've been doing with the children that actually did have COVID and those that had to come into hospital during that period. We know, as Neil said, that most families were avoiding the hospital like the plague. Well, it was a plague almost, but some kids just couldn't do that. So would you like to talk a little bit about your work?
Yeah, thanks, Vicki. So as Meredith eloquently presented, there's a number of the cohorts on campus, which are the community cohorts and the resilience cohorts that you talked about, Vicki. But we've had a really unique opportunity to follow up the children who've presented to the hospital for testing or for hospital admission. And that's either been through the outpatient or ambulatory respiratory infection clinic, or actually those children who've come through the emergency department and then had a COVID test and been admitted either to our short stay unit or onto the wards. And so we've had this really unique opportunity to try and understand the impact of the trauma related to testing and hospital admission, and particularly exposure to nursing and medical staff in full PPE, as well as the full range of mental health impacts, educational impacts, financial impacts, and a lot of other elements of the study as well. But relevant to this discussion, I think, is fascinating. One thing that's come out of our recruitment interviews and our qualitative work, family interviews, we've also had the opportunity to survey youth, so children over the age of 12, is the impact of a positive diagnosis on the child and the family. And what I mean around this is really for parents, the fear and the guilt that they've experienced and kind of the burden of a positive diagnosis and not wanting to share that with other family and friends in some way feeling that they had failed, that their child had had the illness. And of course, we all know that the physical impact of COVID has been very mild in children, but there's been a real sense of judgment and stigma attached with a child who's had a positive diagnosis. And that's also extended into the school setting. So some of these children have been really bullied online, particularly with really unkind and unpleasant emojis, fear of not wanting to go back to school. And then again, children who have been responsible for the closure of a school, being very bullied and feeling isolated at school and not wanting to talk to their peers. So it's been a really fascinating insight into just the impact of a positive diagnosis. And also families have shared with us the stress around some of the inconsistent messaging from DHHS and the Department of Education. And look, they have done an exceptional job, but it's been really hard for parents to follow, you know, if they're a close contact, what do they need to do, the period of quarantine, what tests do they need to have, and so on. And just to say, Vicki, as well, that we're working closely with the Department of Education and DHHS moving forward into term 1 next year to actually try and understand some of this work in schools. So we'll be, you know, doing sort of additional public health surveillance in schools that may have outbreaks, and also a broader sort of school impact surveys to understand some of these issues. But I think stigma has been a really big issue for some children.
Thanks, Margie. I agree. I think it's a really, really difficult issue for kids to deal with. There's a couple of questions in the Q&A that I'll go to now, and please, if anyone's got any questions, let me know. So there's one here that I might answer. So the question is, I'm wondering if anyone has any data on young people with learning difficulties and anxiety, etc., who don't qualify for extra assistance, and how they've coped with changes this year in and out of homeschooling. So as part of the study that I've described, we actually do have a learning disabilities and an anxiety group. We don't have their data in yet, so I can't tell you exactly. But I can tell you a little bit from experience clinically in working with kids who have learning difficulties. And I think it's pretty much a good news story for schools, in that a number of parents who really have been unaware of their kids' learning difficulties and have had to work with them online have really been able to identify problems that are there and understand the difficulties that schools are talking to them about regarding their child. So I think there's an added understanding, and in the families that I've been involved with, they've been in frequent contact with teachers collaboratively rather than in oppositionally, as we see sometimes, until families can accept that there's a problem. I do think, though, that focusing more on the difficulties that those kids have had, it is a real struggle for kids who, in particular, who have neurodevelopmental disorders such as ADHD and autism spectrum disorders, to actually be able to manage the educational load online if they don't have a good enough attention span to be able to cope in class. It's really tough at home. But then from the other side, I think it's interesting that a lot of families report that these kids have actually coped very well at home, that a lot of the stresses that they feel around being different to their peers within the classroom have disappeared. And in fact, those kids have found it quite difficult to go back to school. So, you know, in all of these issues, there's multiple sides and complexities to deal with as we as families work through. So there's no one size fits all in terms of how kids manage. And I'll just go to the second question here. So that is, and I think, Neil, this might be for you, but for others to comment on as well as they like. So do you predict an increase in children in statutory out-of-home care or children on family prevention orders?
Oh, goodness. really difficult, I think, to predict that. But perhaps I can say what we do know currently, and people would know this from the media too, Vicki, in terms of the increased incidence in family violence. So while people were in the severe stage of lockdown, for many families who are already under pressure, that was just an impossible burden. So the increase of particularly alcohol and other substances, the increase in family violence, the lack of opportunities for people to get assistance for family violence. Some of this was because the usual avenues to get help weren't really available for people. And the confidentiality, as we talked for young people, being able to get help. For some young people, their resilience depended on them not actually being in the family home, when the family home for them was, dare I say, sort of toxic environment. One of the challenges, I think, during the lockdown, Vicki, was child protection weren't able to do their normal face-to-face contact with people. So the capacity to do visits in a safe way was very limited, really. Certainly from mental health field, we had to respect the challenges our colleagues in child protection were experiencing, as we were in mental health as well. But I think many people were falling between the gaps. So I guess in answer to the question people are raising, I think the opportunity to do much more early intervention and diversion wasn't available. And I think the services who normally would have been doing that weren't actually operating at capacity, or they weren't actually operating at all. So yes, quite likely it would end up with the terrible scenario where children get removed from their families and need to go into out-of-home care, with all the dilemmas that creates in terms of long-term trajectory. That should be something we try, if at all possible, to avoid. So I would share the concerns. I don't think we know at this point how this data is going to be tracking. Child Protection are certainly very worried themselves centrally about how to monitor that and what's been the impact of not being able to provide that level of service.
Sharon, you've done a lot of work with disadvantaged families in the community. Do you want to add anything to Neil's comments?
I think Neil's absolutely right. We don't actually know the burden or the outcome of what has happened during lockdown, and I think monitoring that will be so essential, so that it doesn't end up that we, number one, can't reverse things that occurred. So I think there's quite a sense of doom and gloom around the impact of the lockdown. But I also think, to your point, Vicki, that some kids will be quite resilient and some kids will be okay, and same with some families. And I think there's a real challenge for us now, for all of our systems, to try and work out who those kids will be and who those families will be. And that's such not a trivial thing for a system to try and respond to, because it won't necessarily be obvious. One of the things that Margie mentioned briefly was our hope that potentially in term 1 next year, we'll do a broader survey of the mental health of kids in schools, because we don't actually know how kids are doing. And that brings many of us, and I'm sure many of the people who are listening to this, a great deal of discomfort, not knowing actually how kids are going. So we've got our studies that Meredith spoke about, which gives us some eyes on kids and families, but actually we don't really know. So now we're starting to see all those services come back online again. We're starting to hear a lot of anecdotal evidence that some families are doing okay and some families are doing really badly. And, Frank's saying the same thing as some of the stuff they're seeing in schools. Same things. You talk to teachers, they're saying the same thing. Some kids are coming back and they're so glad to be back at school, and other kids are just, number one, not coming back, or number two, just not integrating back into the school. So I think with time things will change, and that's why I think if we can do something in term 1 and have a sense of what does 2021 hold for us as a system, will be really, really important. Vicki, Meredith might have something to add to this as well, because her study that she's been working on in particular has got some data on financial stress, which is the other kind of thing that's kind of still in front of us as JobKeeper and JobSeeker, etc., kind of dry out. That economic cliff still ahead of us. I don't know if maybe Meredith wants to answer that.
Yeah, we're certainly finding that those experiences of family stresses like financial adversities are really common across the board. 1 in 3 families experiencing some financial difficulty arising in that first 6 months of COVID, like losing a job or not having the same number of hours, and so having reduced income and so on. But as I mentioned earlier, what we're also finding is that even though in a way COVID is the thing that we're all in it together, we all went through it and we all experienced it, that there are families who are bearing a disproportionate kind of burden of these COVID impacts. And that is, you know, there are those structures, those inequalities that have fed through into the COVID environment, and potentially even will become wider in the COVID environment and post-COVID environment. So that's really problematic and comes back to this concern about, you know, as one of the questions, thinking about even contact with child protection services and so on, where families are, their coping resources are really under strain. So yeah, I think there is that concern there. And then even for families not at that level of risk, families who are really struggling, and perhaps there were families who were already struggling. So how this looks in the longer term, you know, as coping resources are depleted and so on, is going to be really important to track.
If I could just jump in there, you can see, sorry, Vicki, you can see the central role of teachers and schools, can't you, in terms of identifying these children, supporting families, referring if necessary, and our expectations of teachers that they should have that role. And this might be a good time for a shout out to those teachers who have really supported these children and families through a very difficult period. But our data from the schools, from our school project, suggests that many teachers are already feeling overburdened. We call it compassion fatigue. You know, they're so exhausted from supporting children and families and so on. And their role is central, and yet they do need support from other people, and particularly from the health profession.
Good points, Frank. And I think, you know, just from the point of view of teachers' own safety, they were really put in the front line with not a great deal of knowledge about how risky it was to be there in the classrooms, and also had to learn a whole lot of new skills. So I think that they've certainly had their own challenges through the pandemic. So just a couple of other questions in the last few minutes. One of the issues that I mentioned that's come up in the data that we've collected so far is around this issue of telehealth. And I know that there's a lot of emphasis in our institution, at least, and within the Australian Psychological Association, around moves to telehealth. And you know, clearly there are some advantages of telehealth for people that are far away, etc. But I'm wondering whether, as clinicians, we're more happy with telehealth than families might be. And I'm interested in the views of the panel.
Actually, Vicki, I'd love to answer that, because that's something that I'm struggling with enormously at the moment. And like you said, we can all see the value in telehealth and how it's often more convenient for families. But what many of us are finding is they can't navigate the links, the Zoom links that are sent to them, and then you end up calling the family and they may be in the supermarket or in the car or in the park. So the prioritization for the medical appointment for whatever's going on for that family, and it's not necessarily a judgment, is not the same. So the quality of the interaction and the care, I think, can be compromised. So I think we've got to be careful that if we're going to pivot and use telehealth a lot, which I think we will moving forward, we need to really support the use of how to do it well and how families need to prioritise it. Otherwise, I think the quality of that care will really drop.
And to select the children and families that will use it with. So exactly, some children and families are fine, and some of my patients have loved it, and it's been, you know, we've known the family and it's pretty straightforward. For others, as Margie says, you miss the nuances, and it's so hard to establish a relationship, particularly with new patients and new families. It's so hard. You know, you miss the body language, you miss all the nuances of the interaction between the child and the family. So we do need a mixture of both. and as Margie says, very careful patient selection.
Could I support what Frank's saying too in terms of choice? I think that's really important. And I naively thought, Vicki, maybe something like eating disorders would be a challenge around doing a family interview through telepsychiatry. There's a bit of rural, regional, metro difference. The rural people in mental health were telling me their clients preferred that because of the tyranny of distance and long travel times, whereas the metro families weren't. We've also got, I think, a huge problem in all our services in terms of COVID safe distancing that we can actually provide, certainly in mental health. As you know, we have often very inadequate environment that people have to work within where they can't actually maintain the requirements. And we also know that we're not very good at providing IT support for our staff to actually do this work at all. And there's some interesting discrepancies across disciplines, medical, non-medical, about access to laptops, etc. So I think we've got big challenges, but I support Frank and Margie. I think we've got to be offering choice with this too, not a one size fits all. And I can see that we'll have to have that flexibility, even when it is possible to be working face to face. Maybe we'll never go back to that completely, and perhaps that's not a bad thing to be able to have that variety, but to do it in a sensible way that's driven by what person's choice and preference is, rather than forcing it on someone.
Vicki, can I just add, it's really interesting as 90% of the children in your survey didn't like telehealth. And in a broader survey that Harry Hiscox led across the campus and other campuses, 90% of people liked it. So I think it goes to everybody's point, which is for some people it works really well, and for others, and particularly those with children with additional needs, language needs, or complex children, it probably isn't the best. But it was just really interesting. It was exactly the opposite of what you found.
Well, I think our time's up, so that's probably quite a nice note to end on. That we need families to we need to give families choice, and we need to be careful about how we interpret our data for different groups. So Sharon, I'll hand over to you to finish.
Thanks so much, Vicki. And I'm just, I'm conscious of the time, but also I just want to take this time to just thank all of our panellists who just did an excellent job, and particularly Vicki, who managed all of those questions. And for the questions that came through, thank you very much. Just a note that in February next year, we're going to have a global health seminar along the same sort of line. So please keep an eye out for that one. And then finally, the ongoing story around schools is that, as you know, we put out a report that went to DHHS and DT that allowed the kids to go back to school. The full edition, so Margie was a co-author on that. The full report is now available on the MCRI website. So for those of you who are interested in the detail behind that report, and also the detail in the recommendations, that report is now available on the web. And I think it's just a really nice moment when we reflect on research to practice to policy again, that report has now been used to inform what they've done in Ireland and some of the other countries overseas. And we are seeing some really sensible, in our view, very sensible decisions being made overseas to keep schools open. And we're seeing some pretty sobering data coming out of what happens when you close down schools that's coming out. So on that note, I'm going to thank everybody again, particularly thank again the university for hosting this, and hope you all have a wonderful afternoon. And can I say a wonderful end of year holiday for those of you who are having a break. And we'll see you, we'll finally have finished 2020. And here's to 2021 being just a better year for everybody. So thank you, everybody, and see you in the new year.
Thank you.
Sharon.
Bye.